So good afternoon, everybody. Like my topic is submacular hemorrhage, my approach. So management options are many, starting from introduction of TPA, assisted subretinal blood removal, which was first described by Dr. Payman et al. And multiple options are also there for to treat the significant submacular hemorrhage, starting from intravitreal RTPA, intraocular gas, vitrectomy, subretinal TPA, intravitreal TPA, removing the blood with creating small retinotomy, or doing relaxing retinectomy, a large retinectomy, or using the RP colloid patch transplantation. We should know what are the principal causes of subretinal hemorrhage. It is this, what the treatment strategy actually depends on the. I am talking about the neovascular AMD, post neovascular AMD, or PCV induced vitreous hemorrhage. Not talking on the post traumatic vitreous hemorrhage or something else. Treatment strategies depends on the size, duration, distribution, and these are three principal factors. And height of submacular hemorrhage at fovea is also, it has some doubtful role. Generally, I am following this kind of algorithm. I am working for last 10 years. Small size hemorrhage less than 40 cm, you can treat with anti-VEGF, immunosuppressant, or intravitreal TPA. But if it is more than 40 cm, you have to treat it surgically. So if it is confined to the macula, I am coming one by one. Like one, this is the small size, one less than 40 cm, less than 2 weeks duration. So anti-VEGF, immunosuppressant works better in case of myopic CNV with submacular hemorrhage. Like another factor is where I am treating it surgically, that is more than 40 diameter and more than 2 weeks duration, but less than 4 weeks duration. And it is confined to the macula, extending more to the inferiorly, and 2 to 4 weeks duration, where I am using the non-drainage technique, that is vitrectomy along with cocktail injection of subretinal TPA, anti-VEGF, and air. And finally, SFCS gas tamponade you can get. And you can, why I am using TPA? TPA actually it is available in the normally in our eye. That is the factor is responsible for spontaneous resolution of hyphema or vitreous hemorrhage that occurs naturally because of natural coexistence of TPA inside the vitreous cavity or in aqueous humor. But we are using recombinant TPA, that is the antiplase or retiplase or technetiplase that is available to treat embolic or thrombotic stroke. But in this situation, to lyse the submacular hemorrhage, we are using it for the more clot lysis. The usual dose is, I am restricting myself less than 100 microgram, usually 50 microgram. Like in this case of submacular hemorrhage, where I am after doing vitrectomy using subretinal and PVD induction, using this subretinal needle, polytip needle, and directly introducing into the submacular space and waiting for some time. Then again, after waiting for 5-10 minutes, you are injecting this anti-VEGF subretinally, and followed by anti-VEGF, and as well as the filtered sterile air, and finally do the fluid exchange and SF6 gas tamponade. So you can get good kind of result like this. Like other examples, you can see the submacular result, submacular hemorrhage after this treating with this vitrectomy with subretinal cocktail injection. So now coming to another category, significant submacular hemorrhage, more than 2 weeks duration and more than 40 diameter, where it is extending beyond macula, and duration is 4 to 8 weeks. So subretinal TPA followed by removal of the subretinal blood, that is, it is a drainage technique either by retinotomy or retinectomy. So if you are doing a retinotomy, like in this case, vision loss was more than 1 month duration, where I am just after doing the vitrectomy, I am injecting subretinal TPA for the clot lysis and making the retinotomy for the subretinal blood removal. If it is adequate enough, you can make one retinotomy, or if it is not adequate enough, remove all the bloods from the whole subretinal space, so you can make another retinotomy, like in this case where I made it in the supratemporal quadrant, and to remove the blood as much as possible. It is not mandatory to remove the all blood, but some layer of blood may be there at the end of your surgery. You can wait and it will be spontaneously resolved. So finally, you can inject gas or oil tamponade depending on the sites of retinotomy. And postoperatively, you can see good improvement. Finally, sick patient vision was 6/12 after silicone removal and ERM removal, because ERM was formed. Like in this case, where the vision was dropped vision for more than 6 weeks, almost hemorrhagic retinal detachment, you can see it's almost Ora to Ora serrata. It is not only the extent but also the duration is very important, where I'm injecting subretinal TPA, waiting for some time, and then doing the temporal retinectomy after waiting for 10 minutes. You can wait more also depending on the duration, the amount of clot, and remove all the subretinal blood and using PFCL to settle that. Actually you are creating therapeutic GRTs and doing then reposition of the retinal flap and doing laser all around, and ultimately silicone oil PFCL exchange, injecting silicone oil with the left hand, removing subretinal this thing PFCL with the right hand under sandless light. And postoperatively, you can see a beautiful result after 10 months of surgery after silicone removal. You can get 6/36 vision like this. Now coming to the more devastating situation where it is more than 8 weeks duration. So submacular blood removal along with RP choroid patch graft transplantation, like in this case, it is a 3 months old subretinal hemorrhage. It is almost black colored, and you can see the amount of blood. It is so much of extensive, where must be some kind of like RP is totally compromised, where you have to replace the subretinal RP choroid patch graft transplantation. So blood was almost clotted, and it was very difficult to remove the blood as well as the subretinal CNVM part. And practically, it is most difficult part is the CNVM part, because it couldn't be removed. It is very difficult to remove this subretinal CNVM part. Now I'm choosing a relatively healthy area of RP, from where I can use the RP choroid graft, injecting subretinal PFCL to keep the retinal flap away from my working site under sandless light. I'm using curved scissor to get the graft, and under the PFCL you can reposit this graft bimanually or with the help of forceps in the proposed site of fovea, and then you can then you can deposit the whole then reposit the whole retina using after removal of the subretinal PFCL. You are introducing over the retina, deposit the retinal flap, do the laser all around, just like to treat giant retinal tear, and do the all around the laser barrage as well as the graft site, and do the silicone and PFCL exchange under sandless light, like my previously described silicone and PFCL exchange. So postoperatively, these are the few more example of this successful surgery, but not always it is successful. Maybe I should say it is 55 to 60% case you can get the good result, although vision will improve and patient will gain ambulatory vision from PR inaccurate stage. So we have already published our first article, that is long-term clinical outcomes of submacular blood removal along with isolated retinal RP choroid patch graft transplantation in this Indian experience. And second, it is going to be published within, I think, in the month of June. Real-world outcomes and complication of different surgical approach of significant submacular hemorrhage. And in this article, I describe all the algorithm chances, because stray incidence of like some big amount of submacular hemorrhage can be resolved with simple intravitreal TPA, or you can inject any anti-VEGF like long-acting ranibizumab. I'm not criticizing anybody. They are the all stray incidents, but if you follow this kind of algorithm, I think you will definitely gain some kind of success. You may or may not agree with me, but still it is what I'm working for last more than 10 years to gain this kind of algorithm. Thank you.
Thank you, Dr. Boral. I think wonderfully presented, and this is a tough area where actually one has to realize that the best kind of vision that we are going to get is maybe between 636 and 618 at the best in the worst kind of scenarios. And these are patients who are in a hopeless situations, many of them one-eyed. So whatever vision comes back, ambulatory vision is good enough for the patient to, tide over the next phase of his or her life. So I think it was a